Your time starts now. Luna Chen is a 27-year-old female librarian who attends your GP clinic complaining of 48 hours of left eye pain and redness. She describes no preceding injury, with slowly progressive ache and burning sensation to the left eye. She has a history of mild lower back pain that she takes infrequent ibuprofen for and takes no other regular medications. She is a non-smoker and drinks 3 drinks of alcohol 3 nights per week. Her heart rate is 82 beats per minute, blood pressure 118 on 81, her respiratory rate is 12 and her BMI is 22.7. What additional aspects of history would help in developing differential diagnoses? List 5 specific additional aspects of history. All right. Now, hopefully you've all had a couple of ideas put forward from here. I think this is a relatively good question for KFP because it starts off by asking you what are your differential diagnoses, and probably more applicable here is what things lead you to each of those diagnoses. So, of course, we have the dreaded unilateral red eye question. I think this is something that we potentially will see in actual exams. And again, to highlight my exam technique, underlining the relevant details to this question, and in particular when we get to the question itself, focusing in on what is the question being asked. So additional aspects of history in developing differential diagnoses, and listing 5. So I'm starting off by listing out 5 things to make sure that I'm actually going to be answering the question asked, no more, no less. Let's have a look at some of the answers here. So, any case of unilateral red eye, there's a pretty handy framework through RACGP checks and some previous papers through Australian Family Physician. Of course, one of the big things you're going to want to know is, has there been any changes to visual acuities? This could be blurring, diplopia, flashes, floaters, things like that. Anything that's going to change the way the eye is actually seeing. Now, any of those things I think would score you a mark. And I think for this situation, you're probably better off listing one of those things. So, for example, has she noticed any blurring of her vision, or has she noticed any diplopia or double vision? And I would stick to that kind of response. These kinds of things are more answer cues for the assessor's marking to know what kind of things to be looking out for. So again, we'd be wanting to keep it nice and concise, nice and specific, and avoiding any overcoding. So I wouldn't be listing all of those things there. I'd probably just stick to one. Now, different to that would be, has she experienced any photophobia, as we're starting to think of some of our more sinister causes, and has she experienced any discharge from the eye? We're going to have slightly different thoughts of what could be going on if there's things coming out of the eye as opposed to things not. Is the eye itchy? Again, kind of leading into a bit of that kind of atopy kind of area. And was there any preceding activities that may have contributed? Now, they have specifically said there was no preceding injury, but that is not quite the same thing as any particular exposure, and that could be something that brings out, say, a pollen exposure, and again highlighting the atopy, or of course the dreaded grinding, because there's always some kind of construction work or grinding that occurs, and there's a foreign body there for sure. Now, of course, if you're not so comfortable putting something like that down, you could then ask, is there anything like a family history of eye disease or conditions? And I probably would list something to specify down what I'm talking about there. So that would be something like glaucoma, uveitis, or in particular, any autoimmune disorders. Hint, hint, wink, wink, nudge, nudge. We'll come back to that later on. So hopefully you all had some good things on there. If you came up with something different, pop it down in the comments or the chat, and we'll talk about it as we go along. But, of course, that's not why you're here tonight. You are here to keep practicing questions. So without further ado, we'll put another 2 minutes on the clock, and let's bring back the questions. You examine Luna's eye, shown below. She complains the slit lamp light hurts her eye. What features of the eye exam confirm your suspected diagnosis? List 4 features of the eye. Now, of course, that is a little bit small, so I'm going to bring up a larger version just as a bit of advice. Yeah, it does look a bit creepy. All right, as time runs out on the clock, let's bring up some of our suggested answers here. And so, a question like this, where it's giving you that little bit more information, but then asking you that extra question, this is one of the ways in which the exam shows a consultant level of knowledge. So this is presuming from this picture you've worked out what the diagnosis is, and of course this is a case of uveitis. And so Demir, fantastic conjunctival injection and irregular pupil. Absolutely nailed it. And they're obviously the very prominent things. Of course, if you really wanted to kind of get that extra little bit of points, you could specify that it increases towards the limbus, which is that little layer around the pupil where we switch, and you can actually see that faint kind of halo. Let's just go back for a second. We can actually see it is this layer around here, and yeah, Kane, fantastic job drawing red markers on a red eye. Good one. But that is the area we're talking about. And that's specific to this condition as well, being anterior uveitis, acute anterior uveitis. Now, keratic precipitates on the cornea. Again, if we duck back here, that's these little dots we can see over the top here. Again, this is something that's very, very common for this condition. Not always seen, but if it is there, it's one of those kind of pathognomonic kind of indicators. Impaired reactivity to light, as again the pupil becomes tethered, and that irregularity of the pupil is due to catching of the lens on the iris itself. And as it tethers down, as it tries to move about or constrict, that tethering kind of pulls it, and you end up with a regular border to the pupil. And with that, you can see impaired reactivity to light or meiosis. With that also comes decreased visual acuity, although, to be honest, I've just realised that one doesn't really apply to this because we're specifically talking about findings on this picture. So I don't think that one would be applicable, but you would expect that to be a finding clinically. Meiosis or constriction compared to the unaffected pupil. One of the ways it tries to protect itself is to constrict, and we do get that meiosis there. All right, so we'll say 5 potential answers here. And of course, there are a few other ones there that can be seen, but these are the key ones that I think you would pick up from this kind of picture. How did you go? Let me know. And of course, we still have part 3 for this question. So without further ado, let's put 2 minutes on the clock. And your time starts now. The examination confirms your suspected diagnosis. What is the most appropriate specific immediate management action? Right, 4 specific immediate management actions. And I might just update this to 1. Cutting it early because, guys, let's just say the chat has it. This one is, of course, going to need urgent review with an ophthalmologist. So excellent job to Samir, excellent job to Demir. Now, I'm going to be a little bit mean to Demir, sorry, and just to go on about the specificity of answering questions for the KFP. And so if we're saying urgent referral for ophthalmological review, there's a couple of ways that could be interpreted. And so to really nail down the specificity, I probably would specify ophthalmologist, because ophthalmological review could just mean, say, sent to ED for a slit lamp examination, which is one of the reasons why I think you probably still would get the marks, but you would probably want to just be that little bit more careful and specify that it is with ophthalmology. Now, one of the key reasons for this is that you need to actually confirm the diagnosis before you start specific treatments, and you're really wanting to exclude things like endophthalmitis, and check the intraocular pressures before starting things like topical steroids, which would be the mainstay treatment for anterior uveitis. You would also be wanting to consider things like having them try and disrupt the tethering of the pupil to actually restore vision. Now, other things that you could answer would be referral to ophthalmology, which would still get you 1 mark. But again, if we're really trying to narrow down the specificity here, we should be specifying that we know and acknowledge this is an urgent condition. And so without specifying how quickly they need to be seen, you would lose a mark there. Likewise, referral to ED, you might still get a mark. You'd probably be paying it a little bit too risky there. And so I would be always specifying why you're sending them. Now, if you were to try and initiate topical steroids on your own without being able to differentiate those things, I think you wouldn't be awarded any marks. And likewise, any other answer in this kind of setting, really you need to be sending through and acknowledging the urgency of this situation. All right. So well done, guys. Now, something that I think's handy to think about anytime you see practice questions is ask yourself, what if we change this a little bit what would be the things I'd be looking out for? So in this situation, I'd be wanting to know, was there any relevance to the history of back pain? And if you think you know something that would tie the two together, pop it down in the chat or comments below, and I'll post some comments myself. And of course, ask as well, what other conditions can cause irregularity of the pupil? What kind of things would you be thinking of in a slightly different story if, say, there wasn't those same symptoms, but still the irregularity there?